Okay. So good evening, everyone. Today we will start in the new webinar, the fifth one, about total knee principles. It's about the ligament balancing. As we said before, in the first webinar and the first and fourth webinars, we talked about ligament, the bone cuts and alignment of the knee, and how we can do the techniques. So today we will start first. I have no disclosure, and there are some learning objectives in this lecture about ligament balancing in both severe varus and valgus deformities in the knee, and what are these differences between each releases, and the joint stability which we want to achieve that. As far as we know, we have many cases in varus deformity. We will start about it. So anyone can have a specific consideration in this varus knee. So we have the mic, please, if you want to have a mic, and tell us about which are a specific consideration in severe varus deformity with this flexion contracture. It's about 25 degrees. Hey, Karim, سولف. Anyone have a specific consideration before we start? This is the exercise of AP and lateral of the knee. I want for you to share your idea in pre-operative, what you are thinking intra-operatively. ايه يا عمي؟ قول عمي أنيس.
سوري بدي آكل.
لا عادي. معلش فتحت المايك في
From the start, the first impression that we expect to see that is contracture of the ligament in the medial side and lax of the ligament in the right side and the lateral sides.
Sure.
So we want to balancing this because the malalignment of the knee making the contracture in the medial side ligaments and
yes.
lax in the lateral side. This is the first impression we have.
Yes. Okay. And what about the joint contracture and flexion? Is that significant too for the balancing, especially the distal femoral cut? ده اسمعك عمي. Okay, this is true for the contracture of the medial side and attenuation of the lateral side, and we have some osteophytosis in the posterior femur, as well as the patellofemoral joint. If you have any ankylosis, you can see it, but here we don't have it. And especially in varus knee, there may be either patellar alta or baja. And then if you have a flexion or extension contractures, you may have started with a +2 or +4 distal femoral cut in order to restore the extension gap. And we will see that later in these slides. So in severe varus deformity, first of all, we know the history of a genovarum since childhood, and there are many cases with medial meniscectomies. And those who have medial meniscectomy may have, in the previous years, they do a total meniscectomy arthroscopically or open. These open surgeries will causing the gonorrhosis on the medial side of the compartment, as you see in this X-ray. So that's why there is an osteophyte and there is loss of the tibia more than the femur. And these patients will start disability and pain and severe limitation of motion at age of about 50s. And the source of varus deformity is the tibial part. Unlike the valgus, and we will see that later, is the femoral side. So as an introduction, there is a preoperative assessment for the range of motion, for the flexion contracture, and the deformity angle. If there is a varus or valgus stress, you can apply it with the quadriceps muscle strength, especially the quadriceps. We can know how much the quadriceps can do excursion in this deformity. The ACL usually in varus knee are insufficient or deficient. The PCL is less common, unless if you have a fixed flexion contracture or deformity is associated with. So we can use, first of all, the posterior stabilizing knee is effectively and excellent in a good functional outcome. And in severe contracted knee, the condylar prosthesis should be required. So when you are preparing with a severe varus or valgus knee, you have to prepare the manufacturer system with you to have the condylar prosthesis together. So we want in the radiographic views like an AP, lateral standing, and skyline view also to evaluate the patellar tracking with the Q angle to prepare the lateral retinacular release if there is a high Q angle or there is a contracture laterally in there. So the approach and surgical technique is the same of what we choose or what we have chosen before. That is the medial parapatellar approach. You can extend this approach whenever you are requiring, because when we want to do an eversion of the patella, we want to see both compartments together, the medial and lateral compartment, freely without contracting the skin and avoiding the U-shape distally at the skin incision. Also, if there is a very severe contracture, especially in a flexion contracture, you can use one of the quadriceps snip or VY turn down extensile approaches in the knee, especially in cases when you have a patella baja or in a case of high tibial osteotomy. Note that the patellar tendon should be dissected subperiosteally with the cuff of periosteum at the level 1 cm above the tibial tubercle in order to restore this tendon. This is very crucial to avoid injury. And some of the surgeons, they do pinning, one of the pins inside this tendon just above the tibial tuberosity in order to make it not stretch more. All osteophyte then should be removed from the femoral and the tibial sides. An initial medial release is that the progressive medial release are performed from the anterior to the posterior medial side of the tibial plateau, especially when you remove the anterior horn of the medial meniscus and you found that the deep MCL, you can put this gap between them after electrodiathermy and removal of osteophytes from here. You can put the Homan retractor inside to protect the deep MCL. The posterior medial release start in a flexion, as we say, in the after resection of the anterior horn medial meniscus, protection of the MCL with a Homan, we said that, and subperiosteal sharp dissection on the medial side of the plateau 3 to 4 cm downwards. So this is the medial release. We can start it with an affine osteotome, 3/4. They said that it's a 3/4 one, and you can do this up to 3 to 4 cm, not excising into the more distally because of pens and serenas. We want to preserve it as much as possible for further releases. And you can see here these cuffs of the pens and serenas. Subperiosteal dissection is in front of them to protect the MCL. Regarding the distal femoral cut, a standard cut is perpendicular to the mechanical axis, as we see in the preoperative X-ray and templating. This is the line of the mechanical, this is the anatomical axis, and we draw this line of the cut of the distal femur. According to preoperative templating, some authors suggested 4 I-amrod angle with the result of a few femoral varus joint alignment, but this will makes a constant extension gap. And these are this is from JBJS in 2010 that have been suggested an effective post-operative mechanical axis alignment in a 15 years follow-up if you have a 3 degree of varus in the knee joint. However, you can do a medial, a perpendicular cut of the femur. Despite the varus deformity at the distal cut, it's more in medial than in lateral, as resection guide sits in the most prominent condyle, which here we have is the lateral, of course, and the amount of thickness at the same prosthesis, which is 9 millimeter, so we can use the 0 cutting box, or you can have +2 or +4 if the flexion contracture is more than 15 degrees of a flexion contracture. So the preoperative assessment, you can start with the +2 or +4 accordingly. Regarding rotation, we all know that there are parameters, the rotation that must be established in the balance and flexion gap symmetry and minimize the flexion stability. Okay. So some prefer this after extension gap. They do the distal femoral cut and immediately go to the proximal tibial cut. But here we can use it together with the distal femoral cut. So we know these parameters, the 4 parameters, the AP white side line from the sulcus to the top of the notch, the trans epicondylar axis, and the PC axis, which we see it the posterior condyle, 3 degrees internal rotation in relation to the trans epicondylar axis, and this X is the line which is perpendicular to AP line and must be parallel with the proximal tibial cut. In situation where there is a 3 degree of external rotation that is insufficient, you have to increase the external rotation in order to be parallel with the tibial cut. And we will see this in the after this one. This will increase the medial space in a flexion gap. You can see this picture, how is the lateral is more anterior projecting of the posterior condyle, more projecting than the medial, and this line is internal rotation. But sometimes you can see this picture, how is the sclerosis of the posterior condyle, medial posterior condyle of the femur is eroding the tibia and cause more in internal rotation. So if you do 3 degrees of external rotation in relation to the posterior condylar axis, you can see it is not parallel in the yellow line. So we can advance the medial hole of the pin above this part or transferring anteriorly in order to make this cutting box of the tibia, which is parallel with the external rotation for a sufficient medial gap in flexion. Regarding proximal tibial cut, although these are talking about, have been talked about in the previous webinar, however, we can do very small reminding about the proximal tibial cut. We all know that this is the mechanical and the anatomical axis, which are parallel, and we draw this line. And you can see that the blue line is 10 millimeter cut of the tibia from the lateral tibial plateau, which is, as we see, the normal side, although it has some osteoarthritis. So we evaluate, this is the orange line, which is the cut of the proximal tibia, and you see a gap here below this line into the lowest point of the medial tibial plateau. And this will be assessed as follows. As there is a deficient of the medial tibial plateau, the options are, if it is less than 10 millimeter, we can do cementing because this line will be here. So that's why we don't need to augment anything apart from cement. You can drill the sclerotic part with a fine caliber drill bit. If it is more than 50 millimeters, in such case, you can see the defect of the tibia is away from the orange line. And then we can augment the tibial tray and consider an offset stem. Between 10 and 15 millimeter, this is case by case basis solution, which some surgeon added more cement, others suggested a screw cement construct. Okay, this is for the tibial size, and as we see in the webinar before, how the shift and resect technique regarding if we downsize the tibial tray, and we can see this part in the picture on the right. This part has been drawn in the drawn well in the tibial tray, and this can be resected perpendicularly. As you see here in this picture, number one, there is an excess of the medial side of the tibial bone medially. It has been resected with a fine osteotome and make the tibial tray lateralize in order to make the joint line are parallel. So one smaller size is chosen with the laterally shift without overhang in the posterolateral in this area and the tibial cut of the plateau, and rotating the tray using the tibial tuberosity, medial and central third. And the uncapped medial plateau is resected perpendicular to the tibial resection. So the medial structure releases are as the initial release is performed that permits a proper trial component alignment, and then a posterior osteophyte like this picture, we can use it by translating the tibia backwards in order to make the can you hear me now? Okay. Sorry. The posterior osteophyte, as we said, it's a posterior capsular release with the curved osteotome for flexion contracture, and also the medial gastrocsoleus if there is the medial compartment is still tight. And remember that we will do this later after the excision of the posterior capsular and removal of the osteophyte. اعتقد النت يمكن شوي يقطع عندي. Is everything clear now? Okay. So you can see this picture how the osteotome, how the surgeon is doing the posterior capsular release by transferring or translating the proximal tibia backwards, and all the capsule will be bulged up down from the inferior part of the femur, and then with a gooch or an osteotome, a curved one, you can still have a space for dissecting the posterior osteophyte. So the assessment of overall alignment with ligament balancing using a spacer block in both flexion and extension. So regarding assessment of alignment, the extension gap tightness means that the distal femoral cut should be more, alignment of the femoral cutting box in external rotation, which controls the flexion gap. So excessive external rotation causing a gap asymmetry. A semimembranosus bursa is released. Now this is part of the first picture. What we see, we don't use to release everything. You can do only the posteromedial release of the proximal tibia, and then to have a space between the medial meniscus that is resected and the deep MCL, and then you can release, if there is a still tightness, the semimembranosus bursa down, but not further down into 4 cm, not 6, because there will be the pes sensory extended. So release to increase the medial extension gap. So the formal, if there is a still gap, عادة احنا اللي نسويه انه every step you assess either by laminar spreader or the spacer block. So if there is a still in extension, there is gap medially, the formal MCL release is performed when all of above are tried with a persistent medial tightness. This is a rare situation. Here you can do either a release of the fibers anterior in flexion and posterior MCL in extension. We have a mnemonic AFPE. The AF refers to anterior in flexion and PE posterior in extension. This method is using a pie casting technique, either inside out or outside in. There are much controversies about this, but there are no significant difference, and it is not difficult using an 15 blade with either a laminar spreader or a sequential spacer blocks. Some of the surgeons have suggested that the MCL can be also penetrated with a spinal needle, and it has shown there will be no much gap in the medially or laxity of the MCL itself. Whenever it happens, prepare for condylar knee, condylar constraint. So in each steps here, again, in each step, when you have assessed with a spacer block or a laminar spreader, you may have this complication, which is called the residual lateral laxity. According to Scott Richard, he has been shown that in many cases with the lateral laxity, it is accepted. In one of the situations, the first is that when a static alignment of the knee aligned within the mechanical axis, which is not Varus malalignment, not Valgus. And this will lead to more lateral laxity. But this laxity is accepted whenever it is less than 4 millimeter. 4 millimeter, بنخلي إحنا السبيسر block and we put it in extension, and then you do a Varus stress. Whenever you have this rod, this spacer block, you can do the rod alignment. And whenever you have a rod alignment, you can see that there is no Varus deformity still there, and there is acceptable 3 millimeter opening on the lateral side. This is accepted. But whenever you have a large one, so post-operative rehabilitation, like a straight leg raise test with a splint for 1 month, and formerly it was they were doing a cast in valgus knee for 48 hours. This is forbidden now. Or sometimes they maximize the medial release with using a thicker insert. A concern is that the flexion gap stability is affected, but the lateral structures permits the large insert of polyethylene. So you can use resection and releases gradually of the medial side, and then put a large polyethylene insert, which is, this is seen here from intraoperative view. This polyethylene is 10, and you can see in Varus stress, you can see the attenuation of the LCL still lacks, and there are more than 3 millimeters. It was 5, according to the literature. And then they insert a 14 polyethylene, and then with the Varus stress test, there is no gap laterally. This is all about the Varus, severe Varus knee, and then we will now implicate the valgus knee. As an introduction, the typical deformity is an elderly female, and there are history of knocking knees, history of patellofemoral joint discomfort and pain since adulthood, like that in flexion, recurrent patella dislocation, or chondromalacia patelli. There are important views, like you see here in the right side, the standing AP lateral views, how much the valgus is. And here you can see a gonorrhosis on the lateral structure, and the patella, if it is patella baja or alta, again in the lateral view. In the skyline view, you can see in the severe cases that the patellar surface is now has a concave has a concave structure because of the erosion of the lateral condyle of the femur. And here you can see in standing view, knocking of the knees with attenuation of the MCL. These are very important preoperatively. So note about templating. With the long axis film, it shows that the mechanical axis in both the femur and tibia in order to assess the entry point of IM rod. Regarding the tibia, it is whenever we have a valgus knee, you have a lateral bowing, if you can see this one, so that the intramedullary guide or intramedullary device is very difficult to start with whenever you are addressing the tibia. So I prefer to use the extramedullary device. Here you have either to shift the tibial tray medially using the IM rod, or if you are going to do inserted centrally, you may penetrate the cortex distally of the tibia. In regards of the femur, in valgus OA knee, the joint is in hyperextension and stretches the MCL, while in rheumatoid, sharing this clinical picture above, there is a flexion contracture with or without stiffness. So what about varus and valgus arthritis? There are some notes, clinical notes. In valgus knee, it can be tolerated significant joint damage, which is less painful in varus knee. And whenever you have a bilateral varus and valgus, like what we say a windswept, or some books refer as a wind blow knees, the varus knee is that most important or most significant symptoms. The source of deformity in valgus, as we see and we say before, it is the femoral side that causing a hypoplastic lateral condyle, while in varus, the tibia is. Erosion, the central lateral tibial plateau in severe cases with MCL attenuation. And this erosion, we will talk about it later. The peripheral lateral tibial side or tibial condyle is preserved in the tibia. Thus, the defect is contained, unlike in varus. You have a complete loss, sometimes that we are suggesting an augment with a cement or a metal back. So what about femoral address? During addressing the femur, a hypoplasia of the lateral condyle, which exists both distally and posteriorly, as you see in those pictures. The surgeon should resist the temptation of distal cutting to level this defect. Otherwise, you have resulted in two problems. The first one, you have a large extension gap, which attenuates the MCL more, as you see in this picture. This is an attenuation, and if we cut at the level of the defect in the lateral condyle, you may accentuate this one more. And the joint elevation, the joint line will be elevated, which cause a midflexion instability. So in this situation, you put the cutting box at the medial condyle flush and start 0 and raise accordingly according to the gap balance. Also, you have to prepare augments of the distal femur if required. So addressing the femoral side again, a valgus cut will start about 4 or 5 degrees with the intramedullary rod. Some authors suggested a larger valgus cut for 7 or 8. And there are two reasons of low valgus cut of the distal femur. To balance the medial joint line, the MCL, the medial collateral ligament, and put it under lesser tension while weight bearing. As you know that the lesser the overall valgus line, the lesser the tension medially. And some authors suggested 2 to 3 valgus, but it requires a much lateral release. Because the valgus knee, the second reason is that in the distal metaphysis, there is a distal metaphyseal valgus bow, and this may shift the IM rod medially more. So that's why if you started in the center, you have to reduce the valgus cut. Otherwise, some surgeons prefer the same point medially and then increase the valgus cut. But prepare yourself about releasing the lateral side more. Regarding tibial addressing, the central deficit at the tibial plateau can be augmented with using cement or screw, or if large metal augment is used, if there is large. But remember that the central defect can be augmented well. No bone graft can be addressed here for sclerosis. Because of the sclerosis, many surgeons do not recommend the bone graft. So extramedullary device, as we see, it is very better in use. Regarding balancing the ligament, the main aim is a rectangular symmetrical gap in both flexion and extension. In valgus, flexion gap can be tolerate the rotational femoral alignment. As you see in this picture, there is a hypoplasia of the lateral. So the lateral tissues are not extremely tight in severe valgus. Unlike in severe varus, in extension, it can be tolerate this widening or the gap. So using the white side AP line and the trans epicondyle line with using the laminar spreader as in this picture or a spacer block, as you know, to tense the collaterals. An exception is that when a high tibial osteotomy in a valgus more than 30 degree, the femoral rotation should be reduced or there will be an LCL standard release is required. And we will talk about in difficult primary and special consideration about high tibial osteotomy and others if we are doing a total knee in later webinars. So if we do this lateral release, there must be or maybe a medial laxity after lateral release in extension. Healy and Krakow et al. Shows that there is an advancement of the MCL origin when it is resected with the epicondylar osteotomy, as you see in this picture, as a bone block, then advanced it deeply into the metaphysis using anchors. The standard soft tissue releases are, which in this case, according to Healy, I don't have any experience about it, but the standard soft tissue release in valgus, as we know, in tight inflection, you can release the popliteus, in extension, the ITB, and both LC pie casting. Pie casting, which means that this is the pie, the apple pie, and you do casting in order not to blow away if you are putting it in the بالفرن. Then, however, that's why they are called it a pie cast. The order of the lateral soft tissue release, we all depend on Ransal, what we are saying, or what many books say, it is Ranawat and Insal, مختصرها as an abbreviation, Ransal method. So the first step is that the posterolateral corner, the ITB, and then the LCL, and after that, the CCK. This is about Insal. And Ranawat, he suggested that the first step is that the iliotibial tract at transverse incision, about 2.5 centimeter multiple, popliteus and LCL together with the posterior capsule and the head of the gastrosoleus. Periodic use of spacer and laminar spreader are very crucial in this stage. Start transversely inside the posterolateral capsule and the PLC, like the arcuate ligament, the posterolateral capsule below the popliteus tendon. As you remove the lateral meniscus, you can see the popliteus, and below it, inferiorly, there will be the PLC. The popliteus tendon with lateral gastrocnemius head can be preserved as much as possible, and the ITB can be bicrusting transversely in number 8 blade, filling a pop in each spreading or spacer block in regards of varus stress. The LCL bicasting is carried on after that, and avoid release of biceps femoris as much as possible. Lateral retinacular release at the end whenever you can see the patellar is malattacked. In cases when you reach the end result or the final step in releases, the CCK is the best answer or best option. There are many complications, but in short, we have slight limb lengthening. So a consent preoperatively taken up for the patient to lengthen the nib is enough that to raise the opposite shoe site. And peroneal nerve palsy, this is very crucial to understand the risk factors and neuromonitoring, and would be carried on because many of them have been said it is to be a transient. When occurred, release the post-op dressing and put in a flexion splint for 50 to 70 degrees. And these are a valgus stress, shows on the medial side as it opens sufficiently. And this is the Varus stress, shows that the lateral side is much together with the medial side. And this is the preoperative picture of a standing view in severe valgus. And this is the postoperative picture with augment of a screw cement with a good alignment. And these are the photos, standing view, pre and post-op. I think that's all what we have today. And thank you very much for attending. If you have any questions or comments, I'm very happy to listen. Thank you very much.
Thanks, dear Mr. Sinan, for nice presentation.
Thank you, Dr. Ahmed. Okay, let's see if we have. Thank you very much, Dr. Ahmed. ويدكم. If any question regarding this or the previous webinars, I'm happy to listen to. Thank you, Dr. Haida. Thank you, Dr. Ahmed. It's an honor. Thank you. عمي أنيس شكرا. دكتور أحمد حازم، يا ريت إذا عندك فد موضوع ممكن أنه تشاركنا به على الفيروس أو Valgus deformity. I wish that. Thank you, Dr. Anis. Thank you, Dr. Karim. Thank you very much. أشتيدك خويا. Thank you, دكتور زكريا. ممنون. احنا ان شاء الله حتكون الويبينار الثاني همينه يوم السبت عن الكونتروفيرسيز ان برايمري توتال ني. طبعا هو مو بس الريفيجن، يعني احنا راح نركز على موضوع البرايمري until we cover it all and then we will transfer into the revision. اتمنى انه تكونون قد استمتعتم ويانا اليوم، واذا كان عندكم فد استفسار او شيء احنا يا ريت ان نسمعه. مايك لكم اخوان.
ثانك يو دكتور سنان، عاش ايدك.
ويدك دكتور احمد، ممنون جدا
حبيبي. بس استفسار،
اي نعم.
اكو سم سيستم يعني موجوده بالنسبه للتوتال ني
يس
بالفارس او بالفالجاس ديفورميتي، اذا كان التيبيال بلاتو ديفيسيت ان ميديال سايد خلينا نقول.
يس
يعني اكو سم سورت به نخلي فد، يعني هنا موجوده بالسيستم اوجمنت حتى نسوي اليفيشن، يعني سبسكوينت للبونجرافت، يعني ما نسوي بونجرافت، هذين هن موجودات اصلا يعني.
بالضبط استاذ. هو القضيه وين انه احنا if we want to use it in order to decrease the wear rate between the metal back and the tray, they tried to make first of all if the gap is more than 15 millimeter from the proximal tibial cut اول شيء، ونحاول انه اذا كان ما قدرنا انه نسوي construct with screw like the last picture what you see it, construct
cement and
screw. Some of the surgeons they prefer it with no adverse consequences. Actually it is very good option. Metal back augments, they put it and you have to put either a dummy or a short offset stem with the tibia, as well as in the femur if you have a femoral side deficiency. So that's why
sorry. يعني is there any complication for this metal support?
Well, they said that in the long run there will be يعني metal back wear فقط لا اكثر. بس هو الميتال باك اصلا يعني هم مسويه from tantalum. Actually it is costly. هذه وحده من الكومبليكيشن اللي يخليها انه it is so costly because it is
Yes.
tantalum, and that's why whenever you can put it يعني try to reduce the use it اذا يعني كان الديفكت كبير. بس انا عاده اشوف انه whenever I can do a good ligament balancing regarding the medial side, especially in severe varus, without
Yes.
releasing much of the MCL, I can do يعني up to +2 the tibial resection or not 0. يعني اذا كان عندي انا سيفير فارس راح ابدي راسا بالبلس 2 اللي هو 11 ملم تيبيال كات بدال العفو، راح يصير يعني 12 ملم تيبيال كات بدال 10 بالضبط. فممكن ازيد التيبيا but I have to maintain the distal femoral cut in order to make the extension gap and the flexion gap are together in the same or equalized.
Yes, thank you. Dr. Sinan, what about the range of motion accepted in يعني بالنسبة للبرايمري توتال ني؟
Yeah. This is
يعني
one of a
most
crucial
accepted.
question. صحيح.
Yes.
والله شوف دكتور, in the first generation and the second generation total knee, they accepted the 90 to 100 range of motion flexion. Okay. يعني they do not accept 10 degree extension lag اللي هي يعني ما تستقيم كاملة, بس range of motion it's up to 90 or 100. This is for the previous knees. The third generation knee هسه حاليا اول شيء زيدت الكونفورميتي of the tibial polyethylene with the posterior condylar offset. هم شافوا البايوميكانكس of the distal femur بالنسبه للposterior condyle it has an offset that whenever you have an increased conformity with the tibial polyethylene هذه اول نقطه اللي حتزيدنا it will increase the flexion arc motion. النقطة الثانية regarding the arc of motion and especially in the Middle East, they used to have a high flex knee. ولهذا السبب إذا نعرف بزيمر مثلا they name it nowadays high flex generation اللي هو احنا يعني من عنده انه ال offset of the posterior condyle of the femur is very high, يعني الكيرف مالته يرجع لي ورا كلش هواي بحيث انه it will uncap the posterior segment. The second thing is that you can do it intraoperatively by releasing the posterior capsule, and I usually make the posterior translation of the tibia in flexion of the knee up to 90 degrees, and then it will bulge. The posterior capsule and the posterior synovium, it will bulge. And I can see every posterior osteophyte, and you can resect it all. This will permit the flexion without impingement. Yeah. and extension as well, لأنه هو إحنا بالextension هذه إحنا من اللي حنقصها posterior condyle of the femur, you can do extension easily. So these are two methods يعني to increase the flexion arc.
I know this, thank you. But I ask about mainly about the flexion. Extension, yeah, definitely it should be extended يعني 2-3 degree for lag, no problem.
Yes.
But I mean for the flexion in the Iraqi people,
yeah,
they definitely ask what can I do for يعني for squat position and praying.
والله
Is
حقيقة
it permitted in total knee؟
والله حقيقة
يعني squat position or praying.
high flex gen يعني أنا جربت الزمر ويعني هذا واحد من الأمور اللي خلت أنه after the week 10 post operatively after good physical therapy he can do squatting. The patient can do squatting. I have 3 patients only that did a squatting position. يعني اثنين من عندهم هو أصلا يعني صح كبار بالعمر but they have a good body build and they can do flexion completely. يعني نزل دبني زين. البقية يعني they can he was an athlete man يعني 70-year-old وathlete man يعني زين. البقيه الاثنين لا يعني هم اصلا قعدوا سكواتنج بس شنو with a precaution.
Yes, هاي المشكله احنا اللي patient دائما ask about this problem.
After third month والله دكتور تقدر يعني انه advancing the physical therapy you can يعني انا اقول لهم انه يروحون حتى بقاعه حديد يبدون a high
Yes.
flexion. Yeah, they can do hyperflexion of the knee.
Thank you, Dr.
Thank you, sir. Thank you. Okay, I think is there any questions here? نشوف. Thank you دكتور محمد الإيداني. شكرا أستاذ، تسلم لي. Okay, so next week we will meet together in the same appointment, Saturday night, 10 p.m. about controversies in total knee. الأشياء اللي إحنا ناس يسووها هيك وناس يسووها هيك. هي there are many things and we will define it each one and the choice is yours because most of them they are surgical preferences. And then احنا اللي رح نحكي هو ال disadvantage and advantage of each, what is with and what is without or what is against it. Thank you very much for your listening and goodbye. Thank you.